Hello once again, everyone. I'm Dave Meinhardt with the Vattikuti Foundation in suburban Detroit. Thank you for joining us for this Vattikuti Foundation Masterclass. This is a topic I'm very fascinated in because I've learned a lot in my 10 years with the foundation about robotic surgery. And for the most part, we've been focused on the Da Vinci robot and to some extent some other surgical robots, including joint replacement robotics. But we're going to hear from two leaders in robotic surgery from Great Britain that are working with a new robot that we're going to learn a lot more about today, the CMR Versius robot. And Prokar Dasgupta has been a leader in robotic surgery for many years, and also in things like the haptics for robotic surgeons and how to make it so that it's easier and more efficient for robotic surgeons to work. His colleague, Dr. Ben Challacombe, and it's Mr. in Great Britain means doctor over here. It's but he's also one of the leaders in robotic surgery. They both have quite an incredible number of titles and responsibilities in education, as well as being incredible surgeons. And I'm going to turn the meeting over to them, and with a lot of gratitude for them spending time on their Saturday afternoon with us today. So please take it away, and thank you so much for being here.
Great, our pleasure. Well, Dave, thank you very much for the kind introduction. We are delighted to be part of this. I tell you, for two enthusiasts like us who love robotics, we would speak about it at any time of day, any time zone, anywhere. This is what we do. And before I just introduce my friend and colleague, Professor Dasgupta, I was just going to tell you a little introduction to what we're going to be talking about today, from a professional and a personal note. We go back to sort of 2001, where Prokar was just becoming a consultant at Guy's, and had me turn up at his door, and I suppose at that moment fell in love with robotics. Everyone always remembers that Prokar had on his letterhead robotic surgeon, way before we even had a robot or a program, and people had a slight laugh at that. And I can tell you, no one's laughing now, because we then went on to acquire a Da Vinci and have the first program in the UK in about end of 2004, 2003 into 2004. We did the first cystectomies, I think, in UK, and one of the first in Europe. And we've then built up, and we've now, I've become a consultant colleague. I've then been able to get involved with being the sort of clinical lead for robotics, while Prokar has been the academic lead, and we dovetail together. And we have 6 specialties going, and 5 Da Vincis. And what was the most exciting thing, I suppose, in a way, was that we knew a new robot was going to come, a new clinical robot, and there was lots of different chat. And for it to be a British designed and a British sort of produced robot for us was a delight. So we knew that we wanted to get involved with CMR as soon as they had the product. We got a team together, and we're going to tell you really about how you would introduce a new robot into an established program. What are the things that we can do? What are our results? We've both done some cases. We've both sort of qualified as proctors for CMR. And we have a program, of course, with some people that are very robot naive in some specialties, and urology, which we sit in, is the longest established. So over the years, this isn't just about surgeons, of course. This is about the whole team. We've trained, we think, over 40 fellows who are now consultants all around the world, many men and increasingly women from the US and Australia and Europe and the UK. We have 8 surgical care practitioners who are senior nurses who help us with robotics, dedicated robotic assistants, and a team of anaesthetists who do that. And allied to that is the training and the research that comes with it. So you don't have to have that, I don't think, in order to launch a new robot, but it's been useful to have that sort of background. So without further ado, I would like to introduce Professor Dasgupta, who's going to tell us about the robotic CMR introduction. Professor Dasgupta has been the editor of the BJUI for 7 years, which I helped him, 8 years, I think, actually, Prokar. and is also our King's Health Partners Professor of Robotics and the academic lead across our trust. So, my friend Prokar, we're delighted to have you here and to hear about how this has all gone.
Thank you, Ben. I wanted to thank the Vattikuti Foundation, especially Mahendra Bhandari, Raj, and Padma Vattikuti, and Mani Menon, because our Robotics Institute is, of course, the King's Vattikuti Institute. So this has been a long, fruitful relationship. And I want to take you all on a journey, which is a story of 20 years, perhaps even more. So let me, with that, share my slides. So thank you very much. As Ben said, I am the King's Health Partners Professor of Surgery. Just to set the scene, King's Health Partners consists of King's College London, which is the university where I am in. And there are 4 major teaching hospitals associated with it. Guy's Hospital, where Ben and I were this morning, St. Thomas's Hospital, which is where the CMR robot currently is after spending time in Guy's. So that is the hospital across the River Thames, from where you can have the best view of the Houses of Parliament in London. And then there are 2 other important hospitals, King's College Hospital in Denmark Hill and South London and Maudsley, which is our Institute of Psychiatry. So this becomes the largest academic health sciences center in the United Kingdom. So we are very fortunate to be part of this, and here we are. Now, I know that this being the Vattikuti Foundation and us streaming across various sites in India and the rest of the world, that there are a number of cricket fans on this webinar. And I just wanted to give it a minute to recognize these 2 great individuals who have passed away in the last few days. Now, robotics is actually going back 30 plus years. And you could easily say that we are the oldest robotic center in the world, because this was the Wickham Davis years, the late John Wickham, an absolute legend who actually came to the opening of the King's Vattikuti Institute of Robotic Surgery in 2014. And Wickham teamed up with Professor Brian Davis from Imperial. They designed this machine called the Probot. This was a true robot because all you had to do was map the middle of the prostate, and then it would vaporize the prostate by the press of a button. They did 30 odd patients, and history has it that Wickham used to operate in Theatre 7, the legendary Theatre 7 at Guy's, which is where Ben and I both operate during the week. So this is the oldest robotics program in the world. But then this is going back to the late 80s. Everyone thought Wickham was crazy. Of course, now, after his passing, we know that he was a visionary. The first robotics trial in the world, which you probably, some of you will know, but others won't, is this. This is Ben Challacombe's trial with Lou Cavusi. So Ben came in 2001 when I had already been in Guy's for 3 years, and I was about to make the jump to a consultant, and Ben was my first fellow. And this is called Systematic Transatlantic Randomized Tele-Robotic Access to the Kidney, or STAR-TRAK. And STAR-TRAK was the first such trial in the world with Guy's and Johns Hopkins hospitals being part of it. So we were very inspired by Lou Cavusi. I had visited Lou in 1997, I believe, and we were already doing some work with the then ESOP voice-controlled robotic arm. So this was PCNL, and half the procedures were robotic, the other half were putting the needle in with a human hand, and then the robot was controlled by, would you believe it, ISDN lines from the United States to London, and then we took the robot to the other end to make sure that it was not just a fluke, and it showed that the robot was more accurate, although slower than a human hand. So this really should be recognized as the first such randomized trial. We acquired our Da Vinci system thanks to the guys and St. Thomas's Charity, who gave us, in those days, 2003, 1.1 million pounds in grant money. Without this, robotics in UK would really not be where it is today, because we have expanded into nearly 90 systems. So this was our first Da Vinci. And we have gone through every version of the Da Vinci system. We have 5 of these within our organization and a CMR. And we are continuing to expand. So when Ben told me that we have 6 machines during the pandemic, I thought it sounded a bit obscene, but that's where we are. It's really been very, very valuable, because it's not just us flexing our muscles. This really has reduced the waiting list for multidisciplinary robotics during the pandemic. And I'll share some data with you showing how efficient this has been. When I started, the number of radical prostatectomies being done robotically was 1%. And today that number is up to nearly 94%. So this is robotic assisted radical prostatectomy 20 years later in England. And this is data from the Royal College of Surgeons. Now, this is our own data. And you will notice 2018, we had done 750 odd cases. Then we went to 850. During the pandemic, we had dropped to 731 cases. During the first wave, we did over 600 operations. This is published in the BJUI Compass. Our mortality was very different from that reported in the Lancet paper. The Lancet paper had a mortality of nearly 20%. Our mortality was 0.2% across the board. But this is most interesting because we are now, last year, we have done 1,300 cases. I believe in Europe, the only other center doing more than us is in Grenoble, doing nearly 1,500 cases. So we are catching up rapidly, and we are very proud of this. So this really is multidisciplinary and fantastic. This was from Twitter. Paul Cathcart, my colleague, tweeted this. I picked up on this, and these are what are called forest plots. These are independently gathered by the National Prostate Cancer Audit, and this red is our center. Majority are within the lines, which is a good thing. If you are below the line, then someone from the British Association of Urological Surgeons is likely to call you saying something wrong with your performance, really need to audit your data. But we are one of only few centers above the line, and this was treated as the top performing center. So it's not just about volume, it's also about outcomes. And these, as I said, are independently assessed rather than us beating our own drum. There have been a few sobering moments. As you know, there are very few randomized trials in robotic surgery. The Lancet trial of open versus robotic showing no difference in functional outcomes. There is a trial of cystectomy at 15 centers across the United States. And my most humbling moment, the Coral, the only trial having cystectomy, open, robotic, and laparoscopic in 3 arms, where I thought, as did Shamim Khan, my colleague, that we had reduced, at least as a cohort, the complications of cystectomy. But when we put it to the trial, the 90-day complication outcomes in open, robotic, and laparoscopic were exactly the same. So sobering thoughts, and the one thing you mustn't do is make up your trial data. You have to tell it as it is. And if that means that it isn't what you thought it would be, then you have to accept it, learn from it, and move on. What the trials tell us is that the outcomes are dependent as much as on the surgeon's capability rather than just the technology. So the robot is allowing surgeons to get better, but if you put a monkey on a machine, you will get monkey results. So please be aware of that. And please, if there's anything we learn, let us work as a surgical community to get better. Let us turn to improvement rather than saying we have 6 machines. So that's what we as a hospital have been trying to do. We were very aware of this article from David Albala, Robotic Surgery Causes More Regret, and realized that it wasn't just the machine, but actually the counseling of patients about their erectile dysfunction and continence before we operated on them, which is what made all the difference. So this was again a step change some 15 years ago, where we spend a lot of time within a nursing seminar to counsel our patients. And this has made an enormous amount of difference and reduced regret. The other things we have done, Dave just mentioned haptics. I was concerned about the lack of touch. You could argue that 3D HD vision is enough, but here is an indentation probe, which you can drop into the patient, developed in my lab. And you can see these are two anterior prostate tumors that the finger could not feel, but we cut beyond it to make sure we got a negative margin. The other things we did, this is now over 12 years old, is fly in those MRIs. Why should they just remain on a screen into the surgical field? This was the PhD of Steve Thompson, one of my engineers. And then we developed this, which is the translucent system, which was incorporated into the Auris robot. So this is literally like taking an iPad and putting it in front of you, and you can look into your brain. So likewise, you can look through the pelvis inside the human body and look at the prostate. And there is the apical tumor, which you have to be careful about. This uses magnetic tracking as a technology. And just in case you're thinking, well, this is this all remaining in the lab? Well, it is not. This is in a site, which is a company which has come out of surgical and interventional engineering at King's. And this is actually ready for clinical use and has already been trialed by Ben, amongst others, where you can literally see where the calyces are, where the tumor is in relation to the blood vessels, for example, and make surgery more accurate. We also, with EU grant funding, developed a first-in-man system, which was octopus-inspired, called the stiff flop. And this is the first such machine with AI and surgical cognition, i.e. in colorectal surgery, it started learning from the movements of the surgeons. The other thing we did was the world's first 5G robotics. This was on Facebook Live. We hold a patent for this device, which is a little gripper. And then this is from Neurodigital, whereby we can have, with a glove on our hand, feel inside a patient without actually touching them. So this can take the expertise from anywhere in the world to anywhere else using 5G, and now actually in the lab working with 6G technology. We also did, in the last 20 years, the first pediatric 3D printed transplantation. This is little Lucy. Her father's kidney, as you can see, is much bigger than Lucy. So this was used to plan her anomalous blood vessels and where to put this kidney. So this was again a world first, and we took it further to 3D printing in prostates, taking a 3D print inside and planning surgery. This is the 3D printed prostate here. This is the tumor anteriorly, literally a millimeter from the sphincter muscle, and we have shown that we can reduce the positive surgical margins from 35 to 10%. Currently, we are part of the Royal College of Surgeons Mastery study inspired by Andrew Hung. And here is a surgical video. You pass it through the intuitive black box and you get systems data and events data. And you can correlate these automated performance metrics with, say, urinary incontinence and erectile dysfunction. So this is part of a national study where we are looking at Andrew's data in greater detail from our own work. We haven't stopped. So I have just recently embarked on a new lab called Surgical and Interventional Engineering, which is not in the middle of nowhere. It is actually in St. Thomas's Hospital. And this is with Sebastian Orselin, who is head of biomedical engineering. This incorporates the London Center for Artificial Intelligence and Value-Based Healthcare. It has every possible next generation imaging. It has in the center of it a wonderful cadaveric lab, and we have Cambridge One, NVIDIA's most powerful computer in the world, So this will be very, very exciting for us in the next 5 years. So this is in the hospital building, and this will be translatable directly to patients. During the pandemic, we got a massive grant from UKRI on trustworthy autonomous systems. So again, autonomy and the possible trust in autonomy is something that we are very closely working on. We have invested very heavily in the training of our residents. This is from Kamran Ahmed. He, along with the European Robotic Urology section, designed and validated the first robotics curriculum. This is now 10 years ago. It is called the Mars project. And then from there, we went on to non-technical skills, because we realized that a lot happens outside the surgeon console. This is team training, decision making. And then Nick Raison, who was my PhD student at the time, did a randomized trial showing that if you actually think in a defined fashion, which is called mental imagery, often done by sports scientists, you can actually improve your technical skills. So if you look at this, this is the control group of surgeons who just turn up and operate. These are the surgeons who are using mental imagery. The higher the value on the y-axis, the gear score, the better the performance. So this is a better technical skills in a randomized trial. This actually won the Blandy Prize, and some surgeons were very skeptical because they think we are brainless individuals. We aren't. If you do functional MRI, then you can see that in those using that sports analogy, you can get prefrontal to frontal signaling on resting functional MRI. This one, again, the American Science Prize. So we are very proud of what we have done for the education and training of the next generation of surgeons. So that's the background to what we have been doing for the last 20 to 30 years, with a gap in between, because Wickham came 30 plus years ago, then no one believed him, and then we started the new journey 20 years ago. So here we are at the third wave of the pandemic. I had by now been working with CMR for nearly 4 years. I have no conflict, by the way, let's be very clear. I'm not a paid consultant with CMR, neither is Ben. So none of us have any conflicts of interest. But we dared to expand our robotics center further. And we are very proud that this is the first such British machine. And you can see the characteristics. The surgeon is seated at an open console. This is not the first open console. The Zeus robot over 20 years ago was also an open console. There are no foot controls. The surgeon can stand or sit with 3D glasses and control all the robotic arms with their hands. The arms, as you see, are modular. They are smaller and more mobile. So this has really been a team effort. These are some of the images from towards the end of last year. So you can see myself sitting at that open console. Ben just mentioned, this is Jeff, our surgical clear practitioner. Here is Fairly Reeves, who is our fellow from Australia. More about this is Proximi and why we used it. This is the team which trained us, and this is the dedicated team of nurses and even our senior manager who joined in the team effort to make this happen. I particularly wanted to recognize CMR and 3 people, Anna, who is here, Steph, and Pedro, and of course, Mark Slack. I'm not sure Mark has joined us, but your contributions to making sure that we did this safely is much valued. So this is a team effort. I don't want you to think that this is a one-man show. It never has been a one-man show. So what does this team effort involve for the patient? E-learning modules, these take 10 hours. The Versius trainer, which is virtual reality, which takes 6 hours, but actually it takes a lot longer than that, because until you pass these, you are not allowed to progress. And Ben and I were initially skeptical, but I think this is a good thing. Yep, this is the lesson I have learned, is there is a learning curve. Just because you have 20 years of Da Vinci and other robots behind you doesn't mean that there isn't a learning curve. There is absolutely a learning curve each time you move into a new machine, and you can shorten that learning curve by this journey. There is 3-day technical training, of which there's a dry lab and 2 days of cadaveric lab, then a hospital dry run, and then preceptored cases and ongoing support. So this is the journey that we went through to make this happen. Now, as I told you, this was during the 3rd wave of the pandemic. Stefano Guidaro, who was the first preceptor, and he was looking at my hands, was in Italy, and he couldn't travel. So we said, well, no problems. We'll use Proximie, which is developed by Nadine Hakacharam, my plastic surgery colleague. And this is an augmented reality platform which really has globalized and democratized surgery, 7,500 plus procedures in over 40 countries in the world. And there is the surgeon's finger and voice being observed by a preceptored surgeon nearly 5,000 miles away. This is during a colonoscopy. And then you see the use cases in head and neck, colorectal. In urology, this is Archie Fernando, my colleague, who during COVID, the first wave, did a retroperitoneal lymph node dissection, quite a complex case in a young patient, and was mentored by Jim. And Jim's just been from Seattle to us, and he was sitting there in his pajamas at 1:30 in the morning, while Archie was sitting at Guy's doing this operation. So thank you so much, guys. This was one of the highlights and good news stories during the pandemic. So what we did was use the IDEAL framework, which I know has been used by the Vattikuti Foundation themselves for robotic kidney transplantation. So the IDEAL stands for Idea Development, Exploration, Assessment, and Long-Term Monitoring. So this is not just doing a bunch of retrospective cases. This is prospective. There's a very, very clear a priori protocol. It is registered as an audit, and all the data goes into a registry. So this is the IDEAL phase 1 study as from the IDEAL Balliol College in Oxford. And I am part of the IDEAL collaborative currently with Professor McCulloch in Oxford, and we are looking at a number of new things which will soon hit the literature this year. So we followed the IDEAL principle. So this was done in a very scientific manner. So the stage 1 had primary outcomes, feasibility, which was defined as safe completion of the operation with no Clavien Dindo complications to grade 2 or above, and no conversion to open or Da Vinci surgery. And secondary outcomes were operative time, margin status, and early continence in the robotic prostatectomies. So this is the training. This is the surgeon doing the virtual reality training, as you can see, trying to move the instruments. And while, as I said, Ben and I were initially thinking we are experienced surgeons, actually doing this turned out to be extremely helpful. So please do not skip this part of the training and cut corners with whichever new machine you take, because there will be subtle differences which you need to master. Notice also that the surgeon is doing nothing with their feet. All the controls are in the hands. This is the first cadaveric robotic prostatectomy with the Versius, which I did 3 years ago and showed it at the European Robotic Urology section in Marseille. So this is that first video. You can see that everything is reversed. So that is the symphysis pubis, that's the urethra. These are the original instruments, and these instruments have significantly improved in the last 3 years. This is the first video, and it was shown for the first time in Dusseldorf during ERAS, which was one of the first face-to-face meetings. Let me orientate you here. The symphysis pubis is up here. That's the prostate. This is the dorsal vein complex. I stitched the complex rather than cut it and stitch it. So often I'll just cut it cold and stitch it, but in this case, I felt that I should stitch it because the risk of bleeding is less. Here, you can see the scissors are really much improved, as is the bipolar. So this is the bladder neck dissection. This is actually quite a large prostate. The patient was himself a gynecologist, and when he first came to me, he had been referred by another colleague who has referred me patients for a number of years from another hospital. I said to him that I had trained on the machine, but we had not done a first case. You have to be honest. And he said, look, I've been referred to you because of your expertise. You can do whatever you wish as long as I get a decent result. So the ideal first patient, and he has appeared in the press a number of times talking about his own experience. So it was a privilege operating on a colleague. Here you can see the seminal vesicles. This is the left. I'm now dissecting the right seminal vesicle, cold clips at the tips. And once I have done that, the two seminals are held up like the ears of a rabbit. So this is one ear, that's the other ear, that's the prostate. And this is the posterior dissection being done cold. This is the nerves sparing on the right side. He had a very large tumor. So you will notice that this was an incremental nerve spare because I wanted to leave some tissue behind. And here it becomes more obvious. You can see the tissue left behind. There's an additional layer. On the left side, I was able to get closer to the capsule. So this is a higher release on this side. He had some 3 + 4, 7. On the other side, it was 4 + 3. So this is the left nerve spare. Then the dorsal vein complex is cut. As you can see, the urethral length was very good. We had measured it before as 16 millimeters. So this is excellent urethral length. And I tend to toggle the prostate from side to side because that allows me to adapt to whatever the apex may be. So I move the prostate from side to side just like that when I am doing the apex. So that is something I do, and I teach it to my residents, and it helps me get a clear margin at the apex and not damage the rectum while being able to spare the nerves nicely. I'm old-fashioned. Rather than use too much diathermy, I put a sealant at the back, as I have done here. So in case you're wondering what that is, that's a bit of sealant. This is followed by the Rocco stitch. So this is the video in, this has not been made faster twice. This is as in real time. So you can see the movements, and you can see that there is a learning curve to all this because you are using a completely new instrument. So once that is done, I'll just show you a bit of the anastomosis. So here is the anastomosis. Pardon me. I don't know why that has stopped. Let me just try and bring this back. Okay. Yeah, so you can see the movements of the instruments there. And again, this is the anastomosis being done. And the movements of the wrists are, you will notice in the last 3 years, much better than they were with the instruments that I showed in the cadaveric lab. So there's a continuous attempt at improving the instruments to the next generation. So this is the right-hand backhand suture that I put, and then you come across the front and complete the anastomosis. So here then is a robotic pyeloplasty. This is actually Ben's video. Ben, you will remember this. And so this is the pyeloplasty we have done, and we have done a bunch of these. So you can actually straighten the instruments, which you just saw, by the press of a button. So this is very different from current robotic systems, whereby if you go to the extreme movement of an instrument, you can actually straighten it. So here is, you will very soon see that there is a vessel anteriorly. There it is. So the anatomy is very, very clearly displayed. The renal pelvis is pulled up and dissected off the vessel. So this is a classic Anderson-Heinz. We don't cut corners because of suturing. We have the confidence to do this properly. And the majority of our patients will have a proper Anderson-Heinz dismembered reduction pyeloplasty rather than a phaingoplasty or a VY. So I think the instrument gives you the confidence to do this properly because the suturing is easily so much better. One of the differences that I have always taught, and Ben knows this, is I suture the anterior wall first rather than the posterior wall, because the anterior wall, as you can see here, presents itself. And that's what we do. We do the anterior wall first because it's so much easier to do that. So that's what Ben is doing. He's suturing the anterior wall first. Why struggle, I say, to do the back wall if it is much easier to do it like this? So there goes the stent, and now the posterior wall likewise just presents itself and is not a struggle at all. So here is a beautifully done robotic pyeloplasty with the CMR Versius. So the entire anastomosis has been transposed in front of the crossing vessels and reduced. So we have done MAC3 renograms in all the pyeloplasties that we have done. So what about the data? Urologically, we have done 10 patients. In red are the operations which are first in the UK, which are the robotic prostatectomies and the adrenalectomy. There have been 3 pyeloplasties in addition and 2 radical nephrectomies. The average PSA for the prostatectomies was 10.6, 66 years old. There were no conversions, and the final histology was clear margins in all the prostatectomies. And you can see this is ISUP grade group 2 and 2 in 2 patients, grade group 3 in 1 patient, and grade group 5. So we were not choosing patients with tiny, tiny tumors. Of the 4 we did, 2 patients, 50% had immediate return of continence. And the only single complication, which was less than grade 2, obviously, is a leak on cystogram, which required the catheters to stay in for 2 more weeks. This is the full data set on urology: radical prostatectomy 4, nephrectomy 2, pyeloplasty 3, and adrenalectomy 1. This was a benign cortical adenoma. The nephrectomy one was benign. The other one was a renal cell cancer, T1B. And you can see a number of important things here. The positioning time of the arms is reducing. The console time is also reducing as we go along. In fact, by the time we did the adrenalectomy, we had managed to do this in just an hour and a half, and likewise the pyeloplasties. So yes, there is a learning curve, but with everything, as you practice, you improve. We are not the first to have done a robotic prostatectomy. 2 of these were done in France, but there is no published data. So these were certainly the 3rd such operations, but the first in the United Kingdom. Here are a few publications from Versius in colorectal surgery. This is from Dr. Puntambeka in robotic radical hysterectomy, Dr. Kelka, the first in human clinical results, and then Thomas, the preclinical, the stage 0 ideal evaluation published in European Urology Focus. Our own paper is currently under review in a major journal. So the take-home messages: this ideal stage 1 study clearly demonstrates that it is feasible to integrate a new robotic system, the CMR Versius, into an established 20-year program without compromising outcomes. So thank you very much indeed. I'll stop sharing my slides, and then Ben and I will take questions, because we want to keep this very, very interactive. Thank you so much.
Prokar, that's great, and very clear overview of what we've done in the last few months. I'm sure lots of people have some questions. There is the question and answer tab on the link, so please just put them in there. We have got a question to start from Dr. Poonawalla, which is, I think, is obviously a key question, which is, how does the Versius compare in terms of cost effectiveness vis-a-vis Da Vinci? My understanding of the finances of the Versius was that it costs about 1 to 1.2 million UK, which is not too far off euros. And from our point of view, we obviously did the same number of cases and the same number of sessions. That was one of the real worries of our administrative and management team, that we would be less efficient. And of course, we weren't going to do 3 cases in a day straight away, but we managed the same amount of cases and the same amount of slots as we would have managed normally. So we were able to be as productive. And of course, with cancer surgery and the like, that has been a key feature of the NHS. What are your thoughts on the finances, Prokar?
Ben, one of the things I have gone on records about new robotics in general is saying 3 important parts: cost, connectivity, and artificial intelligence. So this is the question about costs. I think as a general principle, having new robots come to the market will reduce costs, and I think CMR is no exception. But perhaps if there are members of CMR here, they might want to switch on their mics and comment on it. But I think CMR have a number of different cost models. They even sometimes say, look, we will support your assistant, or we will support a PhD student. But the cost of disposables and the hardware itself, I think, is very, very competitive. And as more machines come to the market, I think this is good for hospital systems and patients.
Because it's key that it, of course, is significantly cheaper than Intuitive in order to attract people whose institutions may not have as deeper pockets as, you know, we've been very lucky with the charitable foundation, and that is key. But we can still use it for, you know, we've shown it that we've done five completely different types of surgeries successfully straight away. I think one important shout out, really, one of the most amazing things we had was that the team that supported us from CMR were better than we could have imagined. They were absolutely wonderful in terms of nurturing us and the assistants and the theatre staff to implement this. And I know that is perhaps just the UK team, but my understanding is that is a sort of throughout the company. They've worked really hard on their implementation teams being very user friendly, very thoughtful, very kind, very adaptive to the needs of the institution. Prokar, we've got another question from Dr. Chintalapati about, I might be able to speak to this as well, about when do we plan to start using partial nephrectomy? I've seen that the Versius team in Frimley, who are perhaps, other than us, the other, and Royal Free, the one of the 3 big partial nephrectomy centers, they've done some partial nephrectomies. What do you think we can move on to partial nephrectomy?
How do you feel, Ben? I think we can. I mean, you know, the difference is with pyeloplasty, the time limit is not there. Here, once you clamp it, you have to get on with it. So it's a matter of confidence, isn't it? Because you're up against the clock. Why don't you tell us about how you time yourself, Ben, and whether you think with the songs that you play, you might be able to time yourself. So tell us this story. I think it's an interesting story. So tell us.
Oh, well, it's a human factor story, again, as you were alluding to some of the work that we obviously all as urologists feel that you've got a limited amount of time that you can clamp the kidney for before you can cause damage, and that probably is around 20 minutes. Yeah, so this isn't my idea. I stole this from Sam Bayani, from the great surgeon from the States, but I play 5 4-minute tracks, so this stops people shouting out the time to me and worrying everybody and kind of increasing the anxiety of the whole room. We just play the songs, and as long as you're roughly on the 3rd or 4th song when you finish, then you're in good time. That being said, suturing with the pyeloplasty, I mean, I was really impressed with the suturing of the system. I would say that's one of its strongest points. It's the movements are very facile. I was surprised at how easy it was for us to suture. I mean, I know you had no problems with the anastomosis, really. You demonstrated that. We found that fine with the pyeloplasties. So I would be happy to do a partial nephrectomy. It's or several partial nephrectomies. Obviously, I've done a lot of that work. So it's a question, like everything, of building it up and finding, suitable, relatively less complex cases to start with and moving forward. But there is no reason why this system can't do partial nephrectomy very nicely.
You will have to snatch the machine away from St. Thomas's Hospital,
Yeah.
which is where it has gone and is being used by our general and colorectal surgeons. One of the pleasures of working in London is that you are across site. So that is where the machine is. So we'll have to prize it away from St. Thomas's and bring it back to Guy's, although we are all part of the same happy family.
Yeah, well, that was one of the deals of the implementation, was that we would have a look at it as the most experienced robotic team. And I suppose that's probably useful for other people thinking of acquiring one of these systems, that actually putting it in a theatre where we're only changing one thing, which was the robot, as in the anaesthetists were used to robotic surgery, the assistants, the theatre staff, and the surgeons, we were only changing one thing, I thought was actually a really good idea, and it meant that the implementation was easier. And then we obviously brought the St. Thomas's team in, did their training, their nurses came over and worked with us, and then bringing it into a team that hasn't done a lot of robotics. So doing it that stepwise way, I think would be something that we would recommend again. Do you think, Prokar, that, just reflecting on it, are there any things that we should have done differently with the implementation? Any things that we should have, if we were to implement it again, we would do differently? I mean, we had a number of cases lined up immediately after training, which I think was good. We had 10 cases. We did that within 6 weeks, didn't we? Straight after the training.
Yes, absolutely. I think one of the things, Ben, that you and I would both do differently is perhaps to take the virtual reality training more seriously, isn't it? And busy surgeons, oh my God, 10 hours of e-learning, 6 hours of grinding in our sim lab. You and I were a bit skeptical, weren't we? But I think it stood us in great stead. And then going over and doing the 1 day of dry lab and 2 days of cadaveric lab was extremely helpful. And for any aspiring surgeons, I would say, wanting to use the CMR or indeed any other new robot, I think the training is essential. The days of see one, do one, teach one, or have a go really are dead. You have to imagine that the patient is your own family, and therefore do take the training seriously, even if you are already an experienced laparoscopic or robotic surgeon. Yeah. So that's something I would do differently.
Yeah, I fully agree. We thought, we've done 15 years of robotics and X thousand cases, we can just do it. And of course it is different. And if you're going to look after patients well, you have to be trained. And actually, to be fair to CMR, one of the issues we had was that you have to do a certain amount of hours. And that seemed odd to me, because the better you got at the exercises, the more you did in the available time. And actually, you were becoming very, very quick at doing some of these exercises. They've actually changed slightly to being a competence-based system. I don't know if any of their team wanted to comment, but they've recognized that, say there are 15 different exercises. If you can do X exercise and you've done it 10 times in under a certain amount of time, you're kind of signed off on that. And I think that sort of relationship with CMR, where they've kind of taken notice of what we've been saying about those exercises, has been useful, because others coming on now will be more competence based. If you're good and you can get the hang of it, then you can move on to the next exercise. But that sim was good, isn't it? I mean, it actually is it's a pretty comprehensive set of exercises with suturing, diathermy, changing between hands. And with the fact that you haven't got your feet, I mean, you and me were stamping on the floor occasionally, thinking, where are our foot pedals? And you've got to kind of, it's not intuitive, to use the true sense of the word, to start with, because you're just ingrained in doing something else. Prokar, we've got a question from Dr. Siddiqui. Oh yes, congratulations on getting the Padam Shri, the famous Indian award. We should mention that, because that's a huge honor. So yes, congratulations on that, Professor. Any experience in robotic transplant in an obese patient, donor and recipient? Because they are one of our teams, aren't they?
Yep, absolutely. Ayub, thank you for joining us from Mumbai. We remember your visit to us 20 years ago at Guy's, when we were making this foray into lap and robotics. So thank you, and thank you for your kind words. Robotic transplantation, obese, well, we haven't used this system for robotic transplantation in the obese, but we have certainly done a bunch of robotic transplants, both retrievals and actually putting the kidney in with the Da Vinci system. So that is certainly feasible. The ideal study was done by Dr. Menon and Bhandari, along with Ronnie Abaza and others from Detroit. And as you know, Ahmedabad has one of the largest international experiences with that. So generally, and I say this, generally, robotics makes it easier in obese patients, because the machine does not fatigue, unlike a human being. And because the arms are smaller, you can go through whatever layers of fat you have to go through. And I think the minimal access is also better for the obese patient. So that is the general principle, not just for transplantation, but in all patients. Now, I showed the BMI of these patients, and you will see we deliberately kept them below 30. And actually, there was a slightly strange finding, didn't we, Ben, which we have written about in our paper, where we found that in the thinner patients, perhaps, the Versius, we struggled with the Versius. Ben, tell us about the 5 centimeter rule, and I know that CMR have taken that on board and are planning to reprogram the machine to try and deal with that 5 centimeter. Tell us about that. So it was counterintuitive, wasn't it?
Yes, I mean, when you'll start to provide experience in the new cases, we kind of wanted to choose really thin people, because we knew that the anatomy would be easier to see. But actually, you need to have, with the CMR Versius system, 5 centimeters between the skin and the first place of the instrument. The instruments do not activate until they're in at least 5 centimeters. It may be actually from the end of the port, which probably means about, if you pull the ports back and bits and pieces, it probably means about 8 centimeters from the skin, which doesn't sound very much. But if you're dealing with a very thin patient and you've got some things like adhesions up near the ports, or if you're going to consider retroperitoneal surgery, that then becomes a factor. So that was quite useful to hear about that, and therefore select patients who are sort of medium-sized as opposed to extremely skinny patients. But they have now done, they've taken that on board. I think that's being rectified, and people have done some retroperitoneal work with it. So it is possible. It was slightly counterintuitive. So Prokar, we've got another question from Dr. Sivaramaman saying, do you see a situation where the CMR is used for less complex surgeries, hysterectomies, cholecystectomy, hernia, and the Da Vinci being used for more complex work like partials and prostates? Anna from Chennai.
Yeah, and thank you, Siva. Great question. I do not think that's the case. I mean, look at SIUT. I do not know whether Harris Qureshi is here online, but in a center like SIUT in Karachi, where CMR robot has been used within 1 month to do almost 100 cases, including cystectomy, dare I say, including cystectomy, the world's first such cystectomy. I don't think you can limit things to the machine, saying we will use it for simpler and more complex. You may initially, in an experience center, use the CMR to do the simpler things. And while you get more experienced, continue to use the Da Vinci, say you have already used the Da Vinci for 10 years. But I don't think in centers that are going to start robotics and are going to buy the CMR or use the CMR as the primary system, particularly in centers which do not have Da Vinci systems installed, I think the sky is the limit, but start with the simpler cases and then move on to more complex ones. I don't think you should restrict it and divide it into two parts like that.
Yes, and I mean, that would be, I think, our feeling of our trust is that, you know, we are talking about having done something in the order of 5,000 robotic cases in the trust. We're not going to start with the most complex things with a new robot, but there is no reason why, having done several hundred more straightforward cases, we can't build up. And remember, this is version 1, and CMR are actively moving towards a whole range of other pieces of equipment that will be fused with this robot, which will be energy devices and staplers and things that will allow us to take on more complicated work. So yeah, I would agree with that. That start with this, start with the simpler stuff, get a good body of work under the belt, get good results, and then gradually, incrementally move towards the more complex. So, other thoughts on final thoughts on the implementation of the device? I mean, we did the lab, which was 2 days. We did cadaveric lab, which was very useful to actually practice the docking, wasn't it, of all the different ways that you could dock. And for me, with the kidney side of things, to think about one arm over the body or the arms in front of the body. So I think that is key. We're now at a stage where we've got our third team have just trained last week. And we're going to hopefully self-train. So Prokar and I, we're both proctors, and there are some other proctors in the UK who have interacted with us. So the ability to sort of self-train and not have to send people off, I think, will eventually happen once we've got a body of experience. Yeah. That I didn't hear any sort of negative stuff from the nurses on this, really. I mean, the nurses they enjoyed the challenge. They enjoyed the experience. They felt well supported, as we've said, by CMR.
Yep, I agree. And just a few thoughts on the port placement, as you say, Ben. The port placement is not exactly the same as we are used to. So because the instruments and the arms are modular, for example, where you put the fourth arm in a Da Vinci prostatectomy, for someone like me, where my assistant is on the right side, I have a W configuration, but here with the CMR, the configuration on the left side, the fourth arm is lower down. Yeah, so it's not it's lower than the third arm. So one has to figure out, and a cadaveric lab is a good place to figure that out. But then we, on our journey, the journey doesn't stop here. We have moved the robot into surgical and interventional engineering, which, as I said, is a state-of-the-art lab. We have a PhD student designing instruments for transoral surgery. We hope to be the first in the world to be using this for transoral surgery. And of course, the journey continues with the telemetry and artificial intelligence to train the next generation of surgeons better. And then add various things like hyperspectral imaging. Imagine being able to operate at cellular level live. We are about to embark on a trial of this in neurosurgery, not with CMR, but with a different imaging system. But that is the level of precision we want to bring in the next 5 years. So the implementation has been fantastic, but this is the first part of the journey. I think the rest of the journey over the next 5 years will be even more exciting, I feel.
Yeah. No,
and before you wind up, I'll take you, with your permission, I'll butt in here.
Of course.
On the behalf of the foundation, I must thank our long-term collaborators, Prokar and Ben. I'm a great fan of this institute, and I think one of the greatest achievement the Prokar alluded was our 2014 visit to London. It wasn't yet another visit for me to United Kingdom. It had, I was just reminiscing the benefits besides developing friendship with you and establishing one of the iconic Vattikuti collaboration with guys in King's College. And consistently on the behalf of the foundation, we have got support from Ben and Prokar in our collaborative quality initiative. Baby, they have been, thank you very much on the behalf of the foundation for being friends in terms of moving our mission ahead. On the lighter note, thank you for letting us witness Wimbledon. You organized that. And mentioned about our work on Ideal. And perhaps you don't know, myself and Mani squeezed in some time to travel to Oxford, had lunch with Andy McCullough, and we developed, brought first time the Ideal, which was corked inside a bottle, and added with his permission stage 0 for Ideal, and then Mani was great fan and he used it for his precision prostatectomy. Prokar, one question, Prokar or Ben, either of you could take this. With your level of experience of Da Vinci and moving on to CMR Versius, tell me one thing you hate when you sit on open console and one thing you love which you did not have on Da Vinci.
Shall I go first and then Ben? The one thing I hated was not being able to use my feet, Dr. Bhandari. As Ben said, having used all versions of the Da Vinci, I still use my foot clutch because that's how we started. There was no finger clutch in the early days. So for the first case, Stefano Guidaro from Italy, while noticing on proximy the movement of my hands, also noticed that I was stamping my feet on the floor. But this was entirely something I do. So I was doing it automatically. And of course, there's nothing to stamp on. There are no foot pedals. But now I have gotten used to it. What I really love is the open console. I have gone on record saying it is kinder to my neck. I won't name him, but I just on Thursday had dinner with a great friend and surgeon who had to have neck surgery, having done 4,000 cases like this, with the head buried in the console, and has had to have neck surgery. This is like TUR surgeons in the old days doing surgery like that with the eyepiece. So I think the open console is kinder to the neck. I think Zeus had it absolutely right. And I am really pleased that the open console has made a return. In fact, I would go so far as saying that probably the best way of operating is like on a reclining seat in an aircraft where you are slightly reclined and the screen in front of you can also be reclined. So I think even going back a bit would be even kinder to the neck. So those are my one love and one hate. Ben, over to you.
Yeah, no, I would agree with those. And then I would add, obviously, glasses. You have to wear the 3D glasses. And probably because of the mask and the COVID mask with the glasses, it meant that there was, you get a bit of fogging and steaming up. And it feels like there's just a lot of stuff on your head. And the feet thing is unusual. The great thing about the open console, if we're thinking about the team building and the communication and the safety, is that you can very easily look around the theater. I can see if things are changing. I can see instruments before they go into the patient, and so there, that is definitely an advantage. And we thought a lot about how we placed the console, because there's no point having an open console and having the operation behind you. You've got to have an open console. You've got to have the operation in front of you or just to the side of you so that you can see it. And so if you're going to have the open console, the benefit is that you can interact more with the scrub nurse, more with the anaesthetist, and more with the assistants. And so I think that was very beneficial.
a related question, which is often asked to me wherever we travel, that do you think that this space is getting crowded? Certainly, Prokar would agree what we saw at Düsseldorf. I'm very confident that you'll have many more robots in the market. Would there be a general robotic skill set which surgeons will develop, blunting learning curves for different machines, or you'll have to have a learning curve for every machine they shift?
I can give you a non-scientific answer to this. Firstly, I do not think the robotic space is crowded. As you know, only 10% of surgery worldwide, roughly, is robotic. So there is need for expansion, and I think this is good for patients and healthcare systems. And having multiple different systems, for example, in Düsseldorf, we had the opportunity to see the Medtronic Ugo system. We also saw the Kawasaki system, and of course, Germany has the system from Leipzig, the Avatera, and others. So I think this is a good thing. It is going to bring costs down, and it is going to bring in surgical data science, and in the end, be better for our patients and for our community. So the answer to the first is it's not too crowded yet, and I think a few years to go. I think each system is slightly different, and my completely unbiased, non-scientific answer is that because of the subtleties of each different system, while there will be some generic training in technical and non-technical skills, and to that I would add mental imagery and using brain training, I think there's a real role for that, which will expand over the next few years. I think for each machine, the technical part of it is slightly different. And I would urge people who are moving from one machine to the other, that they take note of the fact that it's a different machine and learn how to use that machine and adapt to its subtleties. Because just thinking every machine is the same is fundamentally a mistake.
People may think, oh, well, we've spent a lot of time learning the Versius. How did it go swapping back? And I can tell you on many of these lists, we did an immediate Da Vinci before or after the Versius case, and it was not an issue. There was no getting back used to the Da Vinci. So there is no worry for people who have multi robots in their hospitals that you're going to lose anything by doing this. It's not quite as simple as just hiring a different car, getting in it and driving it, because you are trying to do an operation as well as you can, not trying to drive down a street, which is relatively simple ergonomic task. But I do think that, as Prokar said, there is some generic skills that are transferable, but you must do the training for the new systems.
I have two things for Prokar. One is thank you. As friends of SIUT, myself, you and Shamim were trying to get them a robot, because anywhere in the world, the place deserved robot was that. So at least CMR's biggest achievement is it could reach to the right people, and they will do the justice with the machine they have given. And congratulations, first time we are meeting virtually. I would have loved to meet you in person for your Padma Shri, which is so well deserved. And I think you were traveling to some place, and I called you because I was one of the earliest to know about it just few hours before. Congratulations, is a proud moment for all of us, and we keep looking for your riding over the crest. So thank you once again, Ben. Thanks to you and Prokar for accepting our invitation and sparing your time. And the only point which I meant to say is space getting crowded is not at the negative point, because what I say, 7,000 robots or 10,000 robots still leaves more than 95% of the operating rooms without a machine. And that's why the cost becomes a very, very important factor if you want to move the robot technology for every kind of surgery. And my gut feeling is that people would be much better off absolutely de novo taking a new machine rather than switching over from one machine to the other machine. So thank you very much, Ben. Back to you.
Yep, thank you, Dr. Bhandari. It was just to say, you know, it's been a great honor, and we're very grateful to the Vattikuti Foundation for putting on the webinar and for inviting us, and to CMR for all their support and for producing a great system that we're delighted to be part of, and for supporting us through the way. And of course, mainly to my friend and colleague, Professor Dasgupta, the award-winning Professor Dasgupta, for his wonderful talk. So thank you, Prokar.
Ben, thank you. Dr. Bhandari, thank you. What you didn't say is people like me are inspired by you, because you got the Padma Shri 20 years before I did. So you are the beacon. We follow you, and thank you for letting us be one of very few Vattikuti Foundation centers in the world. We are very proud of our association. I also wanted to thank CMR personally. I don't think we have had that opportunity, but we can at a webinar publicly thank them. And here is the message: wait for the paper. This will be a nice piece of work, and you will be able to critique it online when it comes out. So soon to be in a major journal near you. So thank you for having us. It's been an absolute pleasure. Enjoy the rest of your weekend wherever on earth you are. Thank you.
Gentlemen, thank you so much for your time on your Saturday afternoon today. It was a very fascinating presentation. And I also appreciate all of your work with the Vattikuti Foundation over the years. And I look forward to seeing much more as we move forward with more robots entering the stream for robotic surgeons everywhere. With that, I'm going to say once again, thank you, Professor Dasgupta. Thank you, Mr. Challacombe, for all that you do in your time here today. Good day.